She will be talking about refractory disseminated Cocci with musculoskeletal involvement in a 14-year-old effectively treated with adjunctive interferon gamma.
Hello again. For those who weren't here earlier this afternoon, my name is Sarah Zhang. I'm a medical student at the University of Arizona College of Medicine, Phoenix. Today I'll be sharing this case report titled Refractory Disseminated Coccidioidomycosis in a 14-year-old treated with adjunctive interferon gamma. So just briefly, I'll review the current approaches to treating valley fever. So for mild to moderate disease, we often start first-line treatment with triazoles, including fluconazole and itraconazole. And when the disease becomes more severe or refractory to standard treatment, we often add liposomal amphotericin B to the treatment regimen. However, despite these treatment options, sometimes there's still cases where patients don't respond appropriately and adequately, especially when there's musculoskeletal involvement. So during these recent years, there has been a growing interest in using interferon gamma to treat disseminated Cocci by enhancing the type 1 immunity. And this cytokine plays a crucial role in activating macrophages and promoting a stronger immune response to intracellular pathogens, including fungi. So there's been prior case reports that show interferon gamma use in pediatric and adult population with success, which suggests its potential role in using as an adjunctive therapy. So the case that we'll be discussing today involves a 14-year-old previously healthy African-American male who presented with fever, poor appetite, vomiting, and back pain. And upon examination, we identified a baseball-sized mass on his left lower back, as well as multiple nodular and cystic lesions on his back, jaw, left ankle, and the right hip. He has no known immunodeficiencies, as well as no personal or family history of other severe infections. And he was initially admitted to the oncology service due to the concern for malignancy in the setting of weight loss, fever, and the back mass. And imaging studies showed widespread disease, including a miliary pattern in the lungs, along with hilar lymphadenopathy, as you can see on the CT image on the left here. And there were also re-enhancing lesions in the brain with other extensive musculoskeletal involvement that was also found on imaging. So a whole body PET scan was obtained, and it showed affected areas in the ribs, calcaneum, tibia, midfoot, knees, paraspinal region, and the mandible, as you can see on the CT image on the right here. So further workup included a bronchoscopy with bronchoalveolar lavage and a pelvic biopsy, which both of them showed the presence of Cocci species. And serological tests also showed very elevated complement fixation titers of 512, which is consistent with active disseminated disease. No immunodeficiencies were identified, but there were 2 variants of uncertain significance detected. It's unclear if these variants have any clinical relevance, but it's still important to note that a thorough genetic evaluation in complex cases like this one is important and necessary in the event that there is an underlying immunodeficiency that is undiagnosed and can be addressed. So for initial management, we started the patient on high-dose fluconazole with a 2-week induction of liposomal amphotericin B. And additionally, he underwent 5 surgical debridements with skin grafting because of the extensive osteomyelitis and abscesses, particularly involving the calcaneus and the cuboid. And this was in order to try to attain source control of the infection. And 2 months later, despite this aggressive approach, he continued to have elevated complement fixation titers of 256 with repeat positive cultures. So this demonstrated that the infection was persistent and refractory to the standard therapy. And he underwent additional surgical debridements, and treatment was then changed to posaconazole and micafungin. At this, given that he had poor response to the first-line treatment, immunology was also consulted. And at this point, we started him on subcutaneous interferon gamma at the dose of 50 micrograms 3 times per week in order to try to enhance the patient's immune response. And 4 months later, he was readmitted due to the recurrent drainage from his foot. And figure 1 here shows the MRI of his left foot, showing extensive osteomyelitis of the calcaneus along with intraosseous abscess, and also the osteomyelitis of his cuboid with early abscess formation. So at this point, we were considering to escalate to amputate the affected foot due to the severity of the infection to try to get source control. However, in order to try to avoid the amputation, interferon gamma was titrated up to 150 micrograms 3 times per week. The only adverse effect that the patient experienced were transient fevers up to 102 degrees Fahrenheit within 24 hours of administration, and these episodes became progressively less severe over time. More importantly, he did clinically improve, and we avoided amputation. So since then, the patient has continued to show clinical improvement, including weight gain and the resolution of his symptoms. So after 9 months of interferon gamma therapy, he self-discontinued it, but he continued on micafungin and posaconazole for a full year of treatment. And he remains on posaconazole for lifelong prophylaxis. So this slide, this figure here shows the complement fixation titers over the time course of treatment. So we can see here that there was some improvement while he was on fluconazole and amphotericin B after 2 months, but still very elevated at 256. The titer remained unchanged while he was on posaconazole, micafungin, and interferon gamma at the 50 microgram dose. And as we can see here, once we increased the dose of interferon gamma to 150, the titers dropped much more rapidly and consistently, with it being to 128 after 1 month, and then to 32 6 months later. And some notable laboratory values showed initial leukocytosis with a neutrophilic predominance. He also had elevated inflammatory markers, including CRP, ESR, ferritin, albumin. Most of these pro-inflammatory markers normalized after 9 months of interferon gamma, except for ferritin and albumin. And IgG, absolute CD8, and natural killer cells were also initially elevated. And it's also important to note that the absolute eosinophil count was remained within normal limits the entire time, including at his initial labs. And IgE was not collected at the initial time point to make a direct comparison. So overall, this case demonstrates that immunomodulatory therapy with interferon gamma is well tolerated in a pediatric patient who has severe disseminated Cocci. And our findings also just suggest that interferon gamma can be used as a adjunctive therapy, particularly when there's significant musculoskeletal involvement. And it also highlights the importance of the Th1 response in managing fungal diseases. This case adds to the growing body of evidence that supports the use of interferon gamma in treating refractory Cocci. So moving forward, our goal is to develop a case series that could provide potential guidelines for treating severe disseminated coccidioidomycosis with interferon gamma in pediatric patients. And important areas to address would include timing of when to start interferon gamma, the optimal duration of treatment, the optimal dosing, as well as any adverse effects or contraindications. Thank you for your time and attention.
Excellent talk. Thank you. Any question?
Hi. Thank you for a very thoughtful and interesting case. One of the things I'd like to know, did you do therapeutic drug monitoring of posaconazole? And did it take time to get levels that you would consider acceptable or optimal with posaconazole?
Yes.
What were those levels, by the way, just out of curiosity?
So the MIC that we were aiming for was above 2 for the, I'm sorry, not the MIC, the trough level for posaconazole, 2 and above, even though we're comfortable. There were a couple of times when he was 1.8, but just to kind of.
How long did it take to get consistently above? Royce, I'll defer to you. Would you say 3 for posa, or 2 to 3?
So
for blood level?
Yeah.
I'm sorry, I had a problematic phone. We like 3 to 6 for all the azoles except flu, and we like 30 to 80 with fluconazole.
See, the only concern I have is and I'll defer to my colleagues at UCLA. Sometimes with posaconazole in children and with dosing, we've had a lot of trouble getting up to the desired levels that have been suggested.
So, yeah. So,
yeah, I agree with you.
I mean, just to finish up on the posaconazole, yeah, I mean, it is problematic, obviously. And honestly, what we tried to do recently with kids is force them to take melted butter with every dose of the posaconazole. That we seem to work the best. With this patient, actually, there wasn't a lot of trouble getting him to the desired trough that we wanted it to be, but we never aim for 3 to 6, just to be clear. Our pharmacist would have a lot of problems with that, and that was going to take a lot of dosing. We're typically comfortable with anything, between 1 and 3.5, but
That's the bottom.
But with him,
Using less than 3. We had a chap not long ago that was on 600 a day, 300 in the morning, 300 at night.
and we've had to use those doses on adolescents, but it's also, like there's a lot of controversy, and I would love to see the data around this.
No side effects.
I'm sorry?
Yeah, no hypoglycemia.
No, and
hypertension.
and we've had other patients, not this patient specifically, who are on posaconazole and inadvertently had a super high, levels for a while, and they've had some endocrine side effects. So that's something, endocrine side effects. So yeah, so this is why, and I see some nodding, heads in the background. And I would be interested
My
to-
head nod is that we push to concentrations as high as 3, feeling that we're following the general principle that you push a drug until and unless you try to go to therapeutic tolerance, or the tolerance before you bail on a drug and add and start over again. And the problem, of course, you and I both face, that we face, is that once you get beyond fluconazole, pharmacokinetics in kids are with the mold active azoles are all over the place, and the absorption issues with them as well. So that I guess that I would just say I was going to ask a different question, but I'll make the comment that, yeah, you had a pretty good level, and I don't know what you did next, but I would probably turn that up a little bit more before I would change around.
Yeah, I mean, the only thing is that I honestly don't think that the problem was the posaconazole, as you can see from his titers, right? Like, I mean, the turnaround time from, objectively with the titers, and also clinically, when that conversation about amputating his foot kind of stopped and was like, well, maybe we can save this, was when interferon gamma was added. You know what I mean? Like, that was the one factor that changed in the story.
Well, the titers don't change particularly quickly, and I think that trying to just make therapeutic change, I think a lot of people here would say you can't look at 1 to 2 month intervals and use
Correct.
that with serology and use that to really guide your therapy, because the dynamics of the antibody change are not particularly predictable. I was going to ask the other question, which was that you managed to, I think, save this person's foot.
Honestly,
And
it was his mom who
his
saved
ability to
foot.
walk.
She's the one who refused the amputation, and and
Oh.
ortho, you know what I mean.
So the question I was going to ask is, at what point, that was a big lesion that you were showing in his calcaneus. So at what point was it debrided, and did you get much pushback on debridement? Our orthopedic surgeons, I think, have changed, but let's say 3 to 4 years ago, to get them to debride lesions, they would say, well, why would I do that? Why would that be helpful?
So we were lucky that his orthopedic surgeon is our ID champion. That's what we call her. She's pretty aggressive, and she actually took him to the OR probably a total of 3 or 4 times, along with plastic surgery, with all the grafting that they needed to do. So there was no reluctance in
hesitance or good.
debridement. So yeah.
I was just wondering about the timing of this lesion. How early,
This
is that image from them? Where does this fit into that chart, for example, that you had before? Is this?
Yeah, so this was the last MRI before changing, up titrating the interferon gamma to 150 micrograms.
And so had he been debrided several times by then? I mean, that's a
he's
key
had,
feature.
He had undergone 5+ surgical debridements at that point.
And I would just say that that's the fight that we have to fight. And I would say that whereas at this meeting, once before I've said, gosh, I've never seen the chronic lung disease variants that have been described at this meeting in adults. The very nice symposium last year in Texas, it was last year, right? But in contrast, the multifocal osteo, that is something that unfortunately we're used to seeing in people of this age. And yeah, they are tough to manage, and congratulations on getting this guy down the road.
There are 2 questions online that I'm going to ask you. One is, what was the reason for stopping the interferon gamma?
The patient self-discontinued it on his own accord.
Why?
So
That was their question. Not mine.
there was some compliance
because of
concerns.
adverse
Bottom
events?
line, no, compliance concerns
I
and
see.
follow-up. So it took a lot after he left the hospital to make sure that we keep
I
him in
see.
care and come back to clinic.
And also
So-
they are asking, did you consider measuring antigens?
Yes, and he's still positive.
Yeah, he was 1/3.
Yeah,
to
we saw him.
132.
Someone from our team saw him in February, and his antigen from both urine and plasma were still positive.
So I want to tell you the sad tale of transfer factor. Back in the 1970s, amphotericin was the only drug available to treat coccidioidomycosis. And I saw many, many patients who had very severe disease that was either poorly responsive or not responsive to amphotericin. Transfer factor was a substance that was described by Sherwood Lawrence back in the 60s. And it's a molecule of less than 10,000 molecular weight that had the ability to transfer a positive skin test from tuberculin from someone who had a positive skin test to someone who had a negative skin test by injecting. And we know that a negative skin test to coccidioidin, 1 to 10, was a marker of poor outcomes. So I thought that using transfer factor might be a good way to improve the response in patients who were not responding to amphotericin. But of course, we couldn't stop amphotericin, so we added transfer factor. And I treated probably a dozen or more patients who had a course very much like this young man, who were not responding to amphotericin. Well, this is posaconazole, obviously, but we're adding transfer factor and saw them turn around. So I was convinced that transfer factor was a very good therapeutic modality. And obviously, I believe in double-blind studies. So I did a double-blind trial and found that it didn't do anything at all. So I want to caution you, when you add interferon gamma to a treatment regimen that we know is effective, so you continued it for a longer period of time, and you did lots of surgical interventions as well. So you'd like to focus on interferon gamma as the factor that turned the tide, Maybe it did, but maybe it didn't. Maybe it's just continuation of good medical therapy. And like I said, I was down that road in the 1970s and put a tremendous amount of effort into that. And it's a sad, sad tale.
That's a good point. Thank you.
Thank you.
Can I just ask a quick question for Wasim? So two, use of miconazole, which we don't use in adults, and also difficulty of obtaining interferon gamma, cost issues.
Yeah, so it is a huge challenge. We've had probably 4 patients that I can remember so far that we've started on interferon gamma. Actually, one of them is in the hospital now, and it's definitely a challenge. Obviously, for the hospital, for starting it on inpatient, I'm being told that the 1 month supply is about $30,000, and that's most of the times the hospital has to eat that. So. We developed a system with our immunologists that if we consider this, after we had the first and second patient, then we have to meet with them and pharmacy to kind of justify why it needs to be started in the hospital. And then, basically have the management in pharmacy kind of approve that. And then, obviously for the outpatient world, even though it's more difficult in terms of process, but at least, it wouldn't be a huge cost issue for the hospital because it just has to go through the prior authorization from the patient's insurance. The biggest challenge is when we started on the inpatient side, and that's when most of the times you're going to need to consider it anyway, because those are patients are sick or they're in the hospital and you start thinking about using interferon gamma.
Outpatient, the insurers, you didn't have
Prior authorization, I mean, after, no, it's not an easy process, but there's more people to focus on getting that done. But in any case, all 4 patients that we've had on interferon gamma, they were started on inpatient. But even when they go to the outpatient, I mean, there's still going to be the prior authorization process. So.
I know. Well,
Sorry,
thank
what
you
was
so
your
much
other
for the
question?
wonderful talk
Micafungin?
Thank you.
and a lot of
Oh.
discussion.
So this is completely out of
Before we finish, I wanted to
based on
thank
this
you, Doug and Mitch, for wonderful